afternoon, everyone, and welcome to day 2 of the annual educational symposium of the American Parkinson Disease Association, Connecticut chapter. This year's theme is Technology and Innovation in Parkinson Disease Management. For those of you who were not able to join us yesterday, my name is Rachel Jeffrion, and I am the APDA Connecticut Information and Referral Center Coordinator. Now, don't make me have to introduce myself again and again all week, so be sure to join us every day from 2 to 3 o'clock for the rest of the week with the same Zoom link that was provided to you upon registration for this symposium. The American Parkinson Disease Association, or APDA, is the largest grassroots network dedicated to fighting Parkinson's disease. We work tirelessly to assist the more than 1 million Americans with Parkinson's live life to the fullest. APDA distinguishes itself as the national organization working one-on-one with the Parkinson's community to make every day better. You can find out more about all the resources the APDA has to offer by visiting us on our website at apdaparkinson.org or by calling us at 860-734-6393. You can also call our chapter coordinator, Marlene Argiana, sorry Marlene, at 860-248-9200. Marlene, would you like to tell our audience a little bit more about the awesome Connecticut chapter of the APDA?
Thank you, Rachel. It's wonderful to see so many familiar names, as well as new members from all over the country and the world joining us. The American Parkinson Disease Association, Connecticut chapter, has been in existence since 1984 and now offers 26 support groups and 9 virtual support groups. The chapter has a wonderful group of board members who volunteer their time to support all the programs and services offered by the chapter. As you can see from the slide, the chapter offers a variety of different programs and events. One of our programs that we are most proud of is the APDA Patient Aid Scholarships, that provides financial assistance to people with Parkinson's. We're also happy to inform you that our Optimism Walk will be in person again in October. More information about the details of the walk will be posted at our website as it becomes available. The best way to stay informed is through our weekly e-newsletter that provides information about upcoming programs and events available not only in Connecticut, but throughout the United States. Thank you and enjoy today's presentation. Rachel, back to you.
Thank you, Marlene. And once again, we would like to extend a special thank you to the sponsors of this year's symposium. Thank you to our gold level sponsors, Adamas and Neurocrine, our silver level sponsors, Apda, Acadia, Griswold Home Care, Medtronic, Synovius, and Supernus, and our bronze level sponsors, Brightview on New Canaan and Kiowa Kirin. We will continue to get to know some of our representatives of these sponsors throughout the week. Today, for instance, you get to meet Candy Stone Gagne, representative of one of our gold sponsors, Neurocrine. She will tell us today a little bit about a new medication for Parkinson's disease. You have 30 seconds of fame starting right now, Candy. Take it away.
Hi there. So I'm Candy Stone Gagne. Some of you may remember me from a previous product, but I work for a small company called Neurocrine Biosciences, and we recently launched a new medication for patients living with Parkinson's disease. So for more information about Neurocrine or this medication, you can go to the first 2 links on this slide, so www.neurocrine.com or www.ungentis.com. But I wanted to just take a few minutes to share with you a program that was actually the brainchild of one of our Neurocrine employees. It's called Parkinson's Cards to Heroes. And it was designed to motivate and empower people whose handwriting has been affected by the Parkinson's disease with a purposeful writing exercise, basically transcribing messages of gratitude to healthcare heroes around the nation. And for more information, you can go to www.pdcardstoheroes.com. Have a great day, everybody.
Thank you, Candy. And now the ground rules once again. Note that you have all been muted to minimize unintentional distractions to the speaker from background noise. but we absolutely do want to hear from you. So please feel free to type any questions you may have in the chat box or the Q&A box throughout the presentation. Just click on the icons at the bottom on the bottom banner on your screen and type in your question addressed to everyone. We will have a few minutes after the presentation to ask our speaker your questions. And now to introduce today's presentation is our good friend, John Franz, representative of one of our silver sponsors, Acadia. John, I'm not sure if you're there, but if you might need to unmute for us.
Am I on, Rachel?
We can hear you now.
All right. Well, good thing you can't see me because I'm not that pretty. But I wanted to say good afternoon, everybody. Once again, my name is John Franz with Acadia Pharmaceuticals. First of all, I wanted to thank Dr. DeMarcata, Marlene Argianis, Rachel Jeffrion, Amanda Brill, and the Connecticut APDA for the opportunity to introduce Dr. Ginger Mills. Dr. Ginger Mills, who is one of 5 clinical neuropsychologists working with a team of movement disorder neurologists at Hartford Healthcare's Chase Family Movement Disorder Center. She sees patients with Dr. Leon Mayton at their Stanford location. She completed her doctoral degree from the University of Hartford and her postdoc training at the VA in Boston. Her research interests include prospective memory and effects of trauma on the brain, and she has been a co-author on several publications on this topic. She is on the board of directors for the Brain Injury Alliance of Connecticut, and in her free time enjoys teaching undergrads and the art of dance. With my honor and pleasure, I want to welcome Dr. Mills in her presentation on Parkinson's disease and dementia, past, present, and future. Dr. Mills.
Thank you so much for that introduction. I am very excited to be here with you all. And I'm just going to take a quick second to make sure that I am visible to you all. Okay, welcome and thank you again for that introduction. I just want to make sure that I can be heard okay. Rachel, can you hear me okay?
Yes, we can hear you and we can see you. You're all set.
Excellent, perfect. Welcome again to everyone, and thank you for the opportunity to speak with you all about a topic that I'm very passionate about, which is the brain, behavior, and the interplay between brain and behavior. And so my goal for today's talk is to establish a common understanding of this spectrum of cognition as it relates to Parkinson's disease. And to do that, we're going to take a look at current definitions, terminology, current concepts of Parkinson's disease and dementia, and we're going to touch on some historical perspectives as well to help ground our current understanding. And we'll also touch on some advances and future directions in Parkinson's disease research, which I think will tie nicely to a talk that will be upcoming in the next few days. So first, I'd like to begin with posing the question, what do we mean by cognition? By definition, cognitive processes involve thinking, they involve knowing, the process of remembering, problem solving. And as you can see here on this slide, changes in cognition or thinking skills, as sometimes I refer to, can be described in many different ways. They can be described as difficulty keeping up with conversations, or losing train of thought, mind going blank, for example. Sometimes changes can be described as forgetfulness, also as difficulty with multitasking, or moving from one thing to the next. And these are ways that folks have described changes in thinking. I'd like to touch a little bit more on what I mean by thinking, what I mean by cognition, and talk a little bit about the general domains of cognition. And so we divide thinking skills into 7 different areas, 7 different domains. And I'll touch on each one separately, but I want you to keep in the back of your mind that they don't work independently of each other. They really do work together and they influence each other in many ways. So the first domain I want to talk about is attention. So attention is the ability to focus or to attend to information. And attention can further be divided into other domains such as alternating or sustained attention. We also have processing speed. So this is speed of mental processing. So I like to describe this as how quickly the wheels turn. The next domain is language skills. So this is not just vocabulary, but also includes the ability to use words or understand words. And it includes things like naming objects and also fluency, how fluent a person might be in using their words. The next domain is visual spatial constructional skills. So this is really about spatial relationships and the perceptions of objects in space, such as judging distances, for example, between objects. We also have memory. Memory is a set of mental skills, and it includes various processes as well. It can include encoding, which is information coming in, consolidation, which is the storage of information, or retrieval, how we pull that information out. And the next domain I want to talk about is executive functions. So this is a set of mental skills that includes working memory, flexible thinking, and self-control. And I want you to think of the executive functions as the CEO of the brain, the executive of the brain, that's really in charge of coordinating a lot of different processes to execute behavior. And last but not least, a domain that often folks don't think of when we think about cognition, which is emotionality or mood. And this is a very important area because emotions or mood can really affect thinking skills and how we go about our day-to-day. And this not only includes feelings, such as feeling sadness or anxiety, for example, but also feelings of motivation. The lack of initiation sometimes can be a problem that folks will talk about, and it's not necessarily related to the capacity of the brain, but really a person's desire to do things can impact their thinking skills as well. So I want us to keep that in mind. So I have this picture up because I hope that it'll help illustrate my point in that when you think of a library, for example, that you have this beautiful library here, it's not just one thing, right? So we have tables, we have chairs, we have librarian all the way in the back, we have these books and bookshelves. While you think of this entire place as a library, there are specific components that work together, but also work separately in order to then have this space that we call the library. And cognition is similar. So we have these different domains that I just talked about: attention, language, memory, executive functioning, and they all work in sync to then produce these thinking skills. So as you can see, the relationship between these cognitive components is complex, and they work together, but they also work independently. So a major concern expressed by a lot of people that I might see that are what we classify older adults or adults that are also going through some changes is in their thinking skills are some of these changes above and beyond what might be expected? Are some of these changes in cognition, like I had described at the first slide, are they typical or normal, or are they above and beyond what we might expect for age? And so one of the ways that we try to answer that question, one of the tools that we have, is through neuropsychological evaluation. And what that is, it's an evaluation of thinking skills. And we do certain tests as neuropsychologists to try to understand how these different brain areas are functioning. We try to understand what are the changes. Are the changes in functioning related to attention? Is it related to a memory difficulty? Are the changes more so in the language domain? So our tests help us to understand that a little bit better. And then we also go into talking a little bit about what are some potential reasons why these changes are occurring. And then our ultimate goal is to talk about recommendations. What can we do about these changes? And so I hope as we go along in this presentation, you'll learn more about some of these questions, and hopefully some of them will get answered in general. Before we do that, though, I want to see if you all would humor me, I'm going to invite you to try a task for me. And my goal is to illustrate what some of these domains, how they work together and how they might work. Okay, so I cannot see all of you, so I don't know if you're going to try this or not, and you're welcome to try this or not. It's completely up to you. When you see a picture of a flower, I would like you to raise your hand. And I'm going to repeat that again. When you see a picture of a flower, I would like you to raise your hand. Okay. All right. So as with most things in life, there is a spectrum that occurs. There's a spectrum of cognitive and functional changes that we might see as we get older. And I want to take a moment to talk a little bit about words and labels, because what we do and what I primarily do is I use certain criteria, certain diagnoses to try to describe changes that might be going on in an individual. And a lot of healthcare professionals assign diagnostic labels to try to classify individuals for both treatment purposes, because it helps us convey a large amount of information at once, but it also helps for research purposes, and we'll talk a little bit more about that down the line. They help distinguish certain patient groups. I'd also like to recognize that when it comes to words, they have a lot of meaning. And when it comes to providing certain diagnoses, I'd like to bring awareness to the fact that while it can be very helpful, it can be very challenging for some folks, because words do have power and they're shaped by a lot of unseen things, like your own experiences or experiences that you might have come in contact with in the media, or an individual's perception of what something is. And I've noticed with a lot of my folks that have come to see me is that there's a lot of emotions around the word dementia. And so I hope that we can understand the terminology as we go through this presentation, but I'd like to recognize that this does exist. So when we think about diagnostic criteria and using these labels to try to describe what are some of the changes, we know that they might not always be perfect. They might not always fit into a person's experience. So I want to provide an example. Along this spectrum that you see here, you have certain changes that might be within expectation. You have certain changes that might also be in the mild category, so changes that have occurred but are a little bit milder in nature. And then we have changes that occur that are more significant, and that'll be in this major category here. And we're going to break each of them down. But I want to highlight and recognize what happens when your experiences of changes kind of falls in between, or if it falls here, or if your experiences are in this area. I use these areas to highlight that they might not always be the best fit, but they are very useful, again, to provide an efficient way for clinicians and researchers to really understand a large amount of information. And they can also help folks understand what they might expect down the line. Now, there are several different sets of diagnostic criteria that we use to classify changes. There are different sets of diagnostic criteria for dementia and different ways to describe dementia. And one of the diagnostic criteria that I'd like to introduce you all to, if you haven't heard of it already, is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. And this is a set of primary clinical criteria that define cognitive disorders. And so we're going to first start by talking about this mild category and what that might mean. But first, so regardless if you chose to participate or not, and whether you were able to execute the action or not, I want us to really think about the process of what led to the eventual behavior. So in order for a person to carry out this task, they would have had to understand the words that I was saying, which was the intention that I set just a few minutes ago. They would have had to put together the words to make meaning of it. they would have had to store the information in their memory centers to try to remember what it was that they were supposed to do. And then on this end, the individual would have had to be able to see the flower, perceive it as a flower, connect the vision of the flower, or the picture of the flower, to the intended action or the behavior. That's quite complex. That's a lot of different components for something that someone might just look at, oh, I didn't remember to raise my hand. But it could be along the lines of it was difficult to pay attention, or language might have been difficult to understand or put the words together, or the planning of the action might have been difficult in that sense. So there's a lot of different components just for that one task. So I hope that illustrates how complex the brain is. Thank you for those who tried it with me. So when we're talking about that mild, the changes, and we're describing them as that mild neurocognitive disorder criteria or diagnostic label, what we're looking for is that evidence of modest decline from a previous level of performance in one or more cognitive domains, and that these changes in cognition do not interfere with the capacity for independence. So folks might have a little bit of a harder time doing things that they would have done in the past. But really, when you're in this mild category, these cognitive deficits don't interfere with capacity for independence. When we're looking down kind of in this area of the spectrum to the more significant changes in cognition and functioning, we're in that major neurocognitive disorder criteria. And here, really, the difference is you have this evidence of significant cognitive decline, and then now there's interference with capacity for dependence in everyday activities. So once we're able to classify and try to understand a little bit more of, okay, there have been some changes in thinking. Do we think these changes are in the mild category or the major category? And we also try to understand a little bit more about functioning. Is this individual, has the functioning changed? Are they able to do the things they used to do? Or has that changed significantly? Once we try to answer those questions, the next question that we try to understand is why? Why are these changes occurring? Okay, so when we think of major neurocognitive disorder, and that's that major change in that spectrum, I want you to think of this as an umbrella term. And this very much relates to the concept of dementia. The term dementia is actually subsumed under the major neurocognitive disorder category or classification. And I want you to think about here this as an umbrella, and there are many different reasons why an individual might have these changes. Parkinson's disease could be a potential etiology or reason why a person might have a major neurocognitive disorder. Lewy body disease is another potential reason. Vascular disease is another potential reason. Frontal temporal lobar degeneration is another one. Prion disease, traumatic brain injury, HIV infection, unspecified, so we might not know exactly what's driving some of these major changes, substance use, or a combination of these factors. So there can be many, many reasons why an individual has some of these major changes. So I want us to keep that in mind. And some of those reasons are related to a dementia. For example, a person who might have these major changes due to Alzheimer's disease, that's classified as a dementia. But an individual, for example, that might have had a significant decline in their cognition, a significant functional change due to a traumatic brain injury at the age of 37, we might not use the term dementia for that individual. So I want you to keep kind of that terminology in mind. Okay, so I'd like to just spend just a few minutes looking at some historical perspectives of the term dementia, specifically as it kind of relates to this category of major neurocognitive disorder, because that is a little bit newer. So here we have around the year 2000 BC, ancient Egyptians, while they still held that the mind, or the concept of the mind, was still in the heart and the diaphragm. It was one of the earliest times that we know of where there was talk that age could be accompanied by a major change in cognition, or by a change in memory. And then many writers of the Hellenistic Empire, they wrote about dementia, and they talked about dementia as organic mental disorders. But it was around the first time when the introduction was made to kind of separate neurological disorders from psychiatric disorders. And so, as you can see in my timeline, quite a bit of time has lapsed, because in the Middle Ages, there wasn't a lot of talk of dementia, specifically because of much deadlier epidemics that were going on, like the plague. And another point in time that I want to highlight is when the term dementia was thought to be first coined, which is around the early 1800s by the founder of modern psychiatry. And you see some of the terminology here that's used to describe these changes in thinking. And we shift from that into the 1940s, we shift from that to the International Classification of Disease. It wasn't until the 6th edition, there was a section that included mental disorders, and they were described as an organic brain syndrome. And then in the 1980s, that's when the term dementia was introduced to that Diagnostic and Statistical manual that I spoke of, that 3rd edition. It was in the 1980s that term was introduced. And that was the 3rd edition. And it wasn't only until the 5th edition that we shifted from this terminology that we talk about dementia to using the broader category of the major neurocognitive disorder, although dementia is still very much used in practice and in research. And for certain specific etiology, like I mentioned earlier, the term dementia is still appropriate and used. Okay, so I'd like to shift now, so we have a sense of kind of where we're coming from in terms of terminology. We have a sense of the umbrella term and the etiology. I want to introduce a concept here, or ask you to revisit a concept, because I think it'll be important to distinguish when we start talking about the clinical profile or the cognitive profile of Parkinson's disease dementia. So I want to introduce the idea of pathology and clinical syndrome. When we think about pathology, we're thinking about the brain changes, the disease, the changes that's going on in the brain. When we think about the clinical syndrome, we're thinking about what folks are walking into the office sharing. And as you can imagine, it's very difficult to really get a clear-cut understanding of what's going on in the physical brain without looking at the physical brain. We have made many advances in our tools to be able to do so, but we still very much use the clinical syndrome, what folks are saying and the symptoms that they present with, to really guide our diagnostic choices or our diagnoses. And so when we think about Parkinson's disease specifically, what's going on in the brain, right? We have Parkinson's disease classically associated with the Lewy bodies, those inclusions of the alpha-synuclein proteins. That's the pathology. That's what's in the brain. And the clinical syndrome of Parkinson's disease, things that folks are sharing, resting tremor, rigidity, etc. I want you to think about Parkinson's disease dementia along the same continuum. We have the pathology, what we think is going on in the brain. While Parkinson's disease is classically associated with Lewy bodies, cognitive involvement in Parkinson's disease, such as dementia, is strongly related to the combination of these Lewy bodies with other pathology, such as the amyloid beta and the tau tangles. So that's what's going on in the brain. When we look at the clinical manifestations, what folks are walking into the office with, it's changes in cognition, changes in functioning, and changes in mood. And so I want to make sure we take a little bit of time to talk about that clinical syndrome, right? So the clinical manifestations of Parkinson's disease dementia. As we touched on earlier, different types of major neurocognitive disorders, that umbrella term, different types of dementias can be associated with very different changes in the brain that can then present very different clinically. While one type of dementia might have more predominant changes in memory, other dementias might have more predominant changes in language skills or in frontal executive skills, for example. So some are more memory predominant, or others are more language predominant, or some are some frontal executive predominance. So they can be very different. And in Parkinson's disease dementia, the neuropsychological profile, which is what we look at in terms of thinking changes, these different areas, these different domains, the areas that are most affected early on for folks with Parkinson's disease dementia is the frontal executive skills, that CEO of the brain, the attention, the processing, the executive functioning. Visual spatial skills can also be affected early on. Language skills, a little bit, not as much as other, for example, dementias. Learning and memory might be affected, but it's a different type of learning and memory difficulty than might be seen in other dementias, for example, such as Alzheimer's. With learning and memory, some of the changes that we see in Parkinson's disease dementia is more difficulty with retrieving information, kind of pulling information out versus completely forgetting. So some of the changes there are a little bit different. And mood can also be affected as well. And so I want to bring this back, and you'll see this image multiple times, because I want to remind folks, big takeaway is that there really is a spectrum of changes that can happen, especially as our brains get older. We expect that there might be some changes and some slight declines in thinking, and that's very normal. There are some changes that are beyond what we might expect in that mild category. And when we get to this major category, that's when we look at there have been significant changes in a person's ability to do day-to-day things. And so what I'd like to now transition to is talking a little bit about next steps. What are some of the future directions, for example, within the fields of Parkinson's disease dementia, and kind of where we are now and where we're looking to in the future? And one of the things that that I want to make sure that there's a lot going on, I should say. There's a lot going on in research, but I want to focus a little bit on the predicting aspect of things, or the future aspect of things. So that's a lot of what's in people's minds, what's coming next. So I want to just take a few moments to talk about that. So what we know about Parkinson's disease dementia, or cognitive impairment in Parkinson's disease, is that it's very heterogeneous in its severity, in its rate of progression, and in affected cognitive domains. So no two people look alike with their presentation. We have profiles that are common or typical, and there are also some evidence that suggests that progression from a mild neurocognitive disorder to a major is not necessarily inevitable, right? Some folks might spend their time in that mild neurocognitive diagnosis and not progress to a major neurocognitive disorder. Specifically, the particular sequence and the evolution of Parkinson's disease pathology in the brain and cognitive decline remains unclear. And this is where a lot of the research is trying to understand, when you have folks that are here in this mild area, what are the characteristics of the folks that then progress to the major? What are the characteristics of the folks that don't progress to the major and stay kind of in this mild neurocognitive disorder diagnostic criteria, that stay kind of in this area? And some of the research is really looking at what are those characteristics in order to try to identify the patients that might be at higher risk of developing a major neurocognitive disorder. And some of the ways that the research is looking into doing that is through certain advances in these clinical genetic algorithms. And so currently the state of art of Parkinson's disease dementia risk determination is using these algorithms. And what these algorithms do is they calculate an individual's risk of cognitive decline by combining a whole host of factors, biomarkers. They combine demographic information, they combine clinical information, they combine motor information, cognitive scores, whole host of information to come up with some predictions of who are these folks that might be at higher risk. Now, while that's very exciting because we do need to classify individuals that would be higher at risk for sure, one of the changes that we need to, apologize, I missed my slide here. One of the things that we want to make sure that we're aware of, that there are some of these challenges, are some of the molecular and neuroimaging biomarkers that we might use might be costly or not yet widely available. So some of the data that might be put into some of these algorithms might not be widely available. And also some of the tools that we use, such as neuroimaging, might be less likely to be sensitive early on in when we're talking about detection of changes in cognition. They might be less sensitive early on in the progression. And so that becomes a little bit problematic when research is really trying to understand what are the characteristics that make up these folks that don't quite yet progress down to the major neurocognitive disorder. And so future directions, a lot of research is looking to engage folks in longitudinal large-scale studies. So for those, we need to better classify those folks that are in that early stage of cognitive changes and then follow them over time. Also, some future directions include trying to have ultimately markers of disease activity that are accurate and are sensitive, and also continued efforts to try to understand folks in that prodromal phase. I also want to spend a moment talking a little bit about this concept of brain reserve, cognitive reserve. So we talked about this area of pathology, along this spectrum. We talked about pathology being that changes in the brain, and we talked about the clinical syndrome being the manifestations of what someone might walk into the office experiencing. What we sometimes see, and what's a bit of a conundrum sometimes for providers, is the pathology or the changes in the brain, again, using our tools because we can't physically see them, the changes in our brain, in the brains using the tools, don't always map onto the clinical syndromes. So we might take a look at a brain using our tools and say, wow, I would have expected this person to have a more difficult time. And we're not seeing that that person has more of a difficult time. So in order to try to understand why this relationship might not always be as linear as it looks here, we've developed some hypotheses, and some of these hypotheses have been tested with mixed findings, but I think it's something that's important for us to keep in mind. So we have the brain reserve hypothesis and the cognitive reserve hypothesis. And while they're related, they're conceptually different. The brain reserve hypothesis refers to a brain's ability to absorb any sort of insult and potentially recover. This is often described as a passive threshold model. Essentially, it hinges on the brain's physical health. So some folks might have super, super healthy brains that might not necessarily prevent the onset of anything down the pike like a dementia, but could delay the onset. Similar in thinking is this cognitive reserve hypothesis, which states that enriched cognition or cognitive activities can serve again as this reserve that doesn't prevent dementia or impairments, but might modify the manifestations or might modify the functioning. And so we use these two hypotheses to try to kind of think about why is it that sometimes we're not seeing the pathology really map onto the clinical manifestations. And so I also bring this because I hope that when we start to talk about recommendations, that you understand why it's so important to follow these recommendations when it comes to physical health, brain health, but when it comes to cognitive health as well. Because while we can't necessarily, we don't have the research, we don't have the evidence to definitively say that it will necessarily intervene or prevent, we do know that it can help for some folks. And with that, I'd like to make a quick transition here to talking about what can be done now for folks that are experiencing some changes or aren't experiencing changes, or for folks that have already experienced major changes. These are some overarching recommendations that you may be doing already, but I want to take these last few minutes I have to really encourage you to think about some of these factors. And you've seen these all before, so really thinking about brain health, physical health, right? Making sure that exercise as safe as possible is incorporated into your day-to-day. I often recommend to folks to think about aerobic and strength exercises, of course, speaking with your medical physicians. There's a lot of studies that are emerging specifically on physical exercise and cognition in Parkinson's disease, and the results are very promising. We know that studies in healthy older adults suggest that physical exercise can improve cognitive functioning, especially when it comes to executive functioning, which is that CEO part of the brain that I talked about earlier, which is the part of the brain that can be hardest hit when it comes to Parkinson's disease dementia. So really exercise, nutrition is a really big factor as well. And making sure that there's high intake of fruits and vegetables, limiting processed food. Now, again, when we think about kind of overall health and overall well-being, I want you to make sure that folks are considering not just physical health also, but cognitive health. And I want to talk about cognitive enrichment strategies. And these can be things that really challenge the brain in some sort of way. A lot of folks will say to me, well, you want me to read more books. Books are great, and I'm a big advocate for reading, but these cognitively enriching, what I like to call activities, doesn't have to be just books. It can be things that will challenge your brain. And there's nothing like, for example, spending time with a very excited 6-7-year-old playing some games that provides great cognitive enrichment for folks. So it's sometimes thinking outside of the box as to what the brain can do in terms of these activities. Social enrichment is big as well. And really also when we think about kind of overall overarching compensatory strategies, we want to think about reinforcing, fortifying, and preparing. When we think about reinforcing, I share this with folks, is trying to reinforce the things that are important to you now and provide the structure for those things now. For example, if it's important to you to make sure that you call a certain person every day at 4 o'clock and you're doing fine remembering to do that now, but you're a little concerned about changes, let's provide some structure and let's add an alarm to a calendar, right? Or let's add an alarm or a reminder to prompt you to call that person in the afternoon every day. Let's add that structure. When I talk about fortifying, I like to share with folks that we want to make sure that we try to support those that are also supporting us. And what that might mean is for caregivers or care partners to make sure that there is self-care going on. Because that's going to be very, very important in the journey that you all might be on. And preparing. So when we think about preparing for the future and we think about preparing for example, an emergency, you buy emergency supply kits, you do all of these things so that you're prepared for a future emergency, but it doesn't necessarily mean the emergency will happen, but you want to be ready. And so when I talk to folks about preparing, it's having these conversations about wishes in the future. And I think that's important for families to also consider. And last but not least, for any providers that are out in the audience, I just want to encourage folks, particularly to talk about some of the cognitive aspects of Parkinson's disease with patients. Some folks might not be aware that there can be changes, and some might be quite worried about these changes. And I think it's important to be transparent with what the research says and what it doesn't say and what we don't quite yet know. And I think it's important to also assess cognition and mood regularly and engage patients and folks in planning with their caregivers as well. Okay, that is what I have for you all today. Okay.
Thank you for that excellent presentation, Dr. Mills, and for your obvious passion for your profession. If you all have any additional questions for Dr. Mills, please continue to type them in the chat box on your screens. Amanda Brill, our board secretary of our APDA Connecticut chapter, continues to help me moderate our Q&A session. Amanda, were there any questions for Dr. Mills?
Yes, there were some questions that came in. Let me just pull up here. So the first question is asked from Roslyn, and Sydney. Dr. Mills, how can illusions be handled without antipsychotic medications? Does any formulation and/or dosage of carbidopa levodopa play a role in creating illusions?
Okay, thank you for that question. So I am going to hold off on any medical advice because that's not my area of expertise. But I would like to answer that question as best as I can in terms of what I'm thinking perhaps what might be described as hallucinations or changes in perceptions of reality. And so again, I'll hold off on any of the medication strategies, but sometimes what I like to share with that might help folks when experiencing some of these symptoms of hallucinations or delusions or changes in reality or perceptions in reality is trying to do what's best for relaxation for that individual. So trying to minimize agitation as much as possible can be really helpful. And these can be things that are already soothing for that individual. And so, for example, if there's a lot going on in the environment, if there's music or television or noise, trying to shut all of that sensory stimuli down. Also, if there are other individuals that might be unintentionally kind of the source of some of this agitation, that those individuals politely excuse themselves. And so trying to minimize the stimulus in the environment as much as possible. And that's kind of the acute onset, what you can do in that moment. Long-term strategies are often trying not to argue with individuals about their perceptions of reality and try to reframe it as this is what the individual might be experiencing. And this is the way they're seeing their reality. They're seeing their immediate world, and just recognizing that it might be different from the way you might be seeing your immediate world. And oftentimes fact-checking or trying to change that reality might not be helpful. Sometimes deviating the conversation to something that's known and tangible can be helpful. Sometimes what I might do with folks is we'll do some grounding things like, I hear that you're telling me that this is happening and this is very emotional for you. Come on over here and let's work on this quilt that we've been working on. So we're distracting and also doing something sensory that brings it back to the current reality can be really helpful. So those are just some tips. So I hope that answers parts of your question, but especially if you're under the care of a medical physician, I would definitely ask about the dosage to them.
Thank you. So the next one from Laura says, what are your thoughts on cognitive testing? When should it be done during the disease?
Fabulous question, Laura. Thank you for asking that. I think it can be helpful throughout the course of the disease in different stages, and I think it depends on what the person might need. So early stages, I think it can be very beneficial because we can start to do our evaluation and get a good baseline for individuals, so that if in the future, if changes were to continue to occur or changes were to occur, we have a good sense of what this person is capable of early on, so then we can then compare results across long periods of time. So I think that can be very helpful. I love that question because I think I view my role a little differently depending on the stage that the individual is in. So early on, really trying to help folks understand changes in cognition, what this might mean, and evaluating cognitive strengths to say, hey, these areas are very much intact. Let's make sure that we're using these areas of cognitive strength in our day-to-day. If folks come to me a little bit later in their disease process, I'm trying to also make sure that I understand these strengths. And often I find my role being, how can we maintain as much autonomy as possible? How can we as providers, as a team, as care partners, help preserve as much autonomy for this individual as possible? So I think part of that is really recognizing what are some of those strengths that this individual has, so that we can then use those strengths to in our day-to-day, in that individual's day-to-day. So I think it's important early on if you're noticing changes particularly that are affecting functioning, and there is a question of, I'm curious if this is above and beyond what I might expect, it can be helpful. And then down the pike also, if there are concerns of, has this progressed, or safety concerns, or concerns for capacity, all of those questions are also questions that are answered by cognitive evaluation.
So we're gonna have our last question from Sarah. Does Lewy body dementia exist separately from Parkinson's dementia? Or are they always related? Does Parkinson's dementia exist without Lewy body dementia or disease?
Fantastic question. And I am so glad you asked that question, because I had actually, I'm trying to share my screen again for 30 seconds. Oh, I can't, never mind.
I can stop my share.
Okay, do you mind if that's okay? Thank you. So I'm really glad you shared that question, because that was something I was thinking about talking, but in the interest of time, I had taken this slide away. Okay. All right. So there is, in terms of the research field, kind of this emergence of research talking about Parkinson's disease, dementia, and dementia with Lewy bodies under this umbrella. But I had already introduced so many umbrellas, I didn't want to give you another one. But this umbrella of Lewy body dementia does have these two components of dementia with Lewy bodies and Parkinson's disease dementia. And so there is overlapping clinical features for sure. There's overlapping neuropsychological features. There's overlapping pathology for sure. And so some folks are thinking that they're the same disease, the same pathology, just in a different point in the spectrum. So there is a little bit of kind of research that's still emerging, but essentially we have Parkinson's disease kind of thinking of it as a bottom-up process, with the disease kind of going from the lower parts of the brain emerging to the more of the cortical areas. And then we have the opposite for dementia with Lewy bodies, where we think the pathology is more prominent kind of in these cortical areas and then kind of progressing down. So that's the current thought when we think about these two conditions. So a spectrum with two endpoints.
Thank you for that that answer. You did a beautiful job on such a delicate and complex topic.
Thank you.
For being with us today. I'm going to hand it back to Rachel so she can wrap us up for today.
Thank you. Thank you both. And yes, so today we conclude day 2 of our week-long annual APDA Symposium. Thank you once again, Dr. Mills, for taking some of your precious time to be with us today, and to everyone for joining us. If you have any other questions that we did not get to, remember that there are a lot of educational materials on our website at apdaparkinson.org. And please do join us again tomorrow at 2 p.m. for a very informative and practical talk on home modifications and adaptive equipment to improve quality of life in people with PD from UConn's occupational therapist par excellence, Rhonda Hickey. And please do remember that if you enjoyed today's presentation, consider supporting the APDA with a donation. Go to apdaparkinson.org and click on the donate button. Please also be sure to join us tomorrow, same time, same Zoom link. Thank you again.